Welcome to Profound Conversations. I'm Joya Jefferson Nuri, and I am your conductor on this journey. In our past programs, we have been talking about building trust between the medical profession and their co-workers, who are their patients and the other parts of the medical team. We have talked about that co-working in the transplant community. And we're going to continue that today with a panel of people who know exactly what they're talking about in this, but we're going to add to the mix the rules and regulations about getting a transplant if you have been diagnosed with a psychiatric problem. Getting a transplant if that psychiatric problem is also added to your race or your gender and all of the complications. And hopefully within this hour, we will come up with some solutions that will benefit all of us. Let me please introduce you to our guest. Let me first start with someone I have admired for more than 30 years. Dr. Clive Callender is a transplant surgeon and a professor at Howard University, and we will get into later the monumental work he has done in the minority communities in this country around transplant education and transplant usage. Dr. Callender, please, thank you for joining us today.
It's such a distinct pleasure to be with you and to refresh our memories.
Yes. Our next guest is Dr. Farha Abbasi. She's the assistant professor at the Department of Psychiatry at Michigan State University. Thanks for joining us.
Thank you for including me.
And you've been a part of this family for a while.
Yes, and hope to continue the conversation.
Very good. We now have Dr. Anil Paramesh. I'm so sorry for mispronouncing that. I've been practicing it all day. Thank you for joining us. Dr. Paramesh is a professor of surgery, urology, and pediatrics at Tulane University School of Medicine. Thanks for joining us today.
It's my pleasure. Thank you for having me.
Thank you. We also have with us Dr. Shawn-Paul Harrison. He's the telephone that you see right there, hopefully not for long. He's a physician and organ transplant specialist at the Louisiana Organ Procurement Organization. Dr. Harrison, thank you for joining us again.
Thank you very much. It's a pleasure to be here.
Good. And last but not least, we have Joey Boudreau. He's the Chief Clinical Officer at the Louisiana Organ Procurement Organization also. Joey, thanks for joining us.
Thank you, Joya. Very happy to be on.
Thank you. Joey, I'm going to start with you because I think that of the other people on this panel, we need to get a fuller understanding of this process of organ transplant. And as the Chief Clinical Officer at LOPA, tell me what you do. What is the framework of your job?
So I oversee the organ recovery, organ donation in Louisiana, including family support, also hospital relations, physician relations, as well as the allocation piece where the organs are ultimately end up the homes that they end. So that's my primary role. Now, it's obviously a very strong connection with the transplant side because without one, you can't have the other, right? And the majority of donations that take place with organ transplantation come through deceased organ donors, primarily brain dead organ donors. And that's where people kind of get confused about that whole process.
Mm-hmm. And tell me about the confusion that they have.
So in general, for organ donation to take place, a lot of people think that anyone can become an organ donor. And unfortunately, that's not the case. It's a very small few who suffer a brain injury of some sort. So it's always a sudden event, very tragic. It's never something that's maybe like a cancer or something where someone dies just of a cardiac event. And so because of this, those people have to be put on life support. They try to save their lives at the hospital and the ERs. I worked in the ER way back in my former life. And then unfortunately, the brain dies in some cases. Hopefully they can revive the brain and the person can live on. In some cases, that's not the case. And with those, that's when they have the opportunity to save lives through organ donation.
You know, I want to veer off here for just a moment, Joey, because when I watch organ donation conversations in the movies or on television, it's like anybody who dies, they're going to go harvest your heart. And you're saying that that's not true.
That's not. It's in fact less than 2% of the population dies in a manner that would allow them to become an organ donor. So it's essentially two different ways, but they both have to be a major brain injury. Either someone regresses completely to brain death where all brain function ceases, or they're very near brain death, and maybe they or their family didn't want them to live on life support and decided to withdraw support. And that's the only two avenues in which you would become an organ donor.
Well, that waylays a lot of fears of a lot of populations in this country that said that if you become an organ donor because of your race, they may just kill you so they can get your organs.
That's a great point, and I've heard it. I've been, of course, doing this for over 20 years now, and that's one of the things that's come up more almost than any other myth that we've had. And again, I worked in the ER, and if they don't do everything, the healthcare personnel prior doesn't do everything possible to try to save your life, then you would never actually become an organ donor. They have to do everything on their end so that can happen, because if not, you'll cardiac arrest and your heart will die.
And that's not what you want to happen. It's rather brain dead more than your heart dying. How did COVID affect not only your job, but the number of people who wanted to have a family member's organs donated?
That is a very good question with a lot of complex directions. So one, our primary role, besides obviously saving lives through donation, is to support these families who are suffering through this acute, extreme grieving phase. And in a non-pandemic, there's so many things that we have to tend to, whether it's their personal, emotional, whether they've eaten, whether they understand what's going on with their loved one. But then you throw a pandemic and COVID on top of it, and it created even more difficulties, because of course there's that disconnect. Initially there was a disconnect because they weren't allowed to be in those critical care units. They weren't. So the communication gap that already existed just got further and further apart. So we had to do quite a bit from the family standpoint, that family support, quite a bit of different techniques to try to continue supporting them in the manner that they really needed to be supported.
Right. I want to move down to Dr. Callender. I just wanted to ask you the same question I asked Joey, is when minority communities, generally minority communities, not limited to minority communities, here organ transplant, there's this natural move toward, the Tuskegee experiment, lynching, racism, and all the other things that may conjure in their brains about the transplant process. And in 1991, you founded an organization called the National Minority Organ Tissue Transplant Education Program. Tell us about that organization, but first tell us why you felt there had to be a minority organization around transplant.
Well, I initially became involved in this. I started the transplant program at Howard University in 1973. And as we looked at the situation, the number one problem in transplantation, then and even now, has been the shortage of donors. But the numbers in the minority community were depressing. For example, 70% of the people who were on dialysis in the United States of America were minorities, but yet less than 5% were donors at that time. And so it was clear to me that we had a problem that we needed to solve. And as I looked at the problem, one of the issues was that they alerted me to the data and they asked me to become part of the solution, but they ran out of money. And they said, yeah, we'd like you to help us, but we don't have any funds. So the data was so remarkable and alarming that Dr. James Bateman and I, a psychologist, recognized that this was a problem that we could become part of the solution by going into the DC community and asking them, what is the problem? Why is it that we are so disproportionately afflicted and affected and yet are unlikely to be donors? Mm-hmm. And so we got $500 from Howard University. Mm-hmm. And we went to the community with $500 and did a study to ask them, we had 2-hour sessions with them, to ask them, why is it that African Americans are reluctant to become donors? And they gave us the 5 reasons as well as gave us the solution to the problem. Because they identified first that African Americans were unaware of the fact that they needed organs more than any other ethnic group, number one. Number two, they had religious myths and misperceptions that they thought that after I die, I need my organs when I go to the pearly gates. Or I also won't be able to see great grandmama in the hereafter, or I won't be able to see them, or if I don't have my heart, I don't have my organs, I won't be able to get there. Forgetting that it is a new heaven, a new earth, a new body. And you don't need your organs. The organs you have here, if you don't use them here, they're going to be disintegrate. So that was the second. The third had to do with basic distrust. As you mentioned, we have a history, the United States has a history of experimenting and using minorities as guinea pigs. And this then was something we had to overcome. And to overcome this, we need to have people like you and I who are actually part of the system. So the distrust was the third very important item. The fourth had to do with a basic concern, as Joe had mentioned earlier, Joey, I'm sorry. And that is that if I sign a donor card and go to the hospital, they might be more interested in getting my organs and tissues than with saving my life. Mm-hmm. And then, of course, the fifth one is something that we hear forever, and that is racism. Concerned that if I leave my organs, they're only going to go to white people. But what came out of this study was that when we started this study, there were 40 people. Only 2 signed donor cards before we started the study. Mm-hmm. At the end of the 2-hour sessions, all 40 signed donor cards. So this said to us that we have the solution right here. So we use the same modus operandi that we use here to have a person who's a donor, a person who's a recipient, healthcare provider, and go into the community and educate, and this will make a difference. To make a long story short, over time, as a consequence of this effort, the number of minority donations in the United States has doubled since we started this program. The number of African Americans who donate have quadrupled. So we've made a difference, but don't think for a minute that we are close to coming to the solution to the problem, because 17 people still die every day because of the shortage of donors, but we have made a difference.
Okay. Thank you, Dr. Callender. I appreciate that. And I'm sure everyone on the panel and our audience appreciates that. One of the things I want to shift to now are the rules for who gets to receive an organ. And the American Society of Transplant, AST, has guidelines around this. And so instead of reading what these guidelines are, I'm going to ask Dr. Abbasi, who is a psychiatrist, who does teach and is part of this transplant world. What are those rules when it comes to people who present with psychiatric problems, but they're on the donor list?
First of all, it's an honor to be on the same panel with Dr. Callender, and thank you so much for the amazing work and your service. I think the point that bothers me as a mental health advocate is that stigma around mental illnesses, right? And this stigma always arises from lack of information, not having that awareness. I think what we don't know, we always would fear that. So it's very interesting that currently 1 in 4 Americans access mental health or are suffering from mental illnesses, this is like pre-COVID numbers. Right now, after COVID, it's 1 in 3 or 1 in 2. So you cannot silo mental health anymore. You can't just say, oh, we are going to exclude mind from the body. We know now, after COVID, what we saw is that those who were depressed got impacted with COVID, but those who got impacted with COVID will go on to develop depression, anxiety, dementia, other mental illnesses. So this division that somehow the mental health has to be separated from the main medical field is where the problem is coming from. So the criteria says that anybody having an IQ level below 35 cannot get organ transplant. It's a contraindication. Beside that, if you are a psychotic, if you have schizophrenia, if you are severely depressed, if you have had multiple suicide attempts without any support, these are all considered absolute contraindications. Resistant depression, which is going to be so prevalent in the society right now. What we are seeing, like all the insults, I would say the trauma of being in a pandemic, the socioeconomic meltdown, the health disparities, all that is going to have impact where? On your mind, on your mood. Yeah. So to me, it's so arbitrary. It's very interesting as physicians, as providers, we are God player, like in the sense we are dealing with life and death, but we start playing God. And that's where the concern comes, that who decides this, that who is severely depressed? Who can decide that if somebody has attempted suicide, that automatically they shouldn't be considered? Or if you have autism, or if you have Down syndrome, that you should not be considered for transplantation. It's not our decision to make. We should revisit these criteria, and we should look at it from not from maleficence, but beneficence and sense of justice.
I watched a movie starring Kelsey Grammer on Tuesday evening called The God Committee. And it is about organ transplant. And as a layperson, and informed by this, by the honor of hosting or conducting these conversations, I was appalled that the standard for who got an organ had to do with the possibility of success rate for the hospital. That they didn't want to transplant to anyone who could possibly reject it, go out and get drunk and go back to their alcoholism or whatever it was. But the measure was, how can we have success here? Never the consideration of their humanity. And so I offer that to anyone, and Dr. Abbasi, you can answer it if you like, but to everybody about the process, including the psychiatry of the psychological health of the people who are eligible for these organs. How close was the God Committee to being true? And I know you will all probably get spanked if the answer is yes, but I would like to hear that answer.
Even how we are screening for depression and suicide, risk of suicide, those models are not designed to keep minorities in mind. They are very standardized normative to white population. So already there is no way we don't have culturally appropriate sensitive tools to kind of predict risk of the severe depression and suicide in minority settings. So that's another health disparity issue that I want to throw out there.
Okay. Dr. Paramesh.
Hi, Joy. Thank you for having me, and once again, honored to be with the panel. Dr. Callender, I've been doing transplant for more than 20 years, but yet when I was training, I was reading your work. So thank you for being such a doyen in the field. To the question at hand, there's several points I'd like to bring up, so please indulge me. So The God Committee is a controversial movie. I've personally not seen it, but I know the gist of it. There have been plenty of talk around it among the transplant circles. But the simple answer to the question is, yes, that's true. What you saw there is true. Transplantation, for better or worse, is measured by the success rates. Transplant centers are graded both by patients, insurance companies, and the government by your success rates. If you have a lot of organs that fail, you will be punished and you cannot do transplants anymore. So the transplant surgeons, as myself, have to wear two hats. One is we have to take care of patients, but we also have to be a good standard bearer for the organs. We can't allow organs to get wasted. Are there disparities in this country? Of course there are, but you can choose so many parties that are disparate. Do we compare the old versus the young? Do we compare diabetics versus non-diabetics? Do we compare African Americans to white people? There are disparities in all of those mechanisms. Underinsured versus well-insured. All of them have differences in their outcomes, and all of them will have differences in how this is going to affect the transplant centers. So the problem that we have, and Dr. Callender alluded to this, is that we're currently in a losing battle. Imagine a scenario where we have a very scarce resource where there are not enough organs for everybody. Somebody has to lose. So at some point of time, utility has to come into the question as well. We all want equity, but utility is a separate quality that we also have to look at. And at some point of time, utility and equity will clash. Everybody can't be equal if you kind of look at utility. So I also chair the American Society of Transplant Surgeons legislative and regulatory group, and I've been in this space for over 10 years, looking at some of the regulations in transplant centers, trying to reduce it, because too much restrictions make it harder. And every regulation that comes about has a downstream effect. So many years ago, we thought about we have to match the organs to the best person. But as Dr. Callender alluded to, there are more white donors than Black donors. So theoretically, those will genetically match closer to a white person, right? So in the match run list, white people will get some priority because it's a white donor. So because of that, UNOS, which is the organization that runs transplant rules in this country, has reduced the dependence upon genetic matching, just so that other minorities can get a better chance at it. And there's been so many other things that have been changed for the purpose of opening it up to minorities. But we've had to make some changes towards utility as well. In 2014, the rules were changed whereby older people don't get the same priority for a younger organ than a younger one does. I mean, is it fair that a 70-year-old is on the same list as a 20-year-old for a young kidney? No, the people say that, well, a 20-year-old should have a better chance at a better kidney. They can go on to have children, they can have a family, they can get a job, they can produce to society. What is that? How much is it going to help a 70-year-old? They might get a couple of years of extended life, but they'll probably die with that kidney still functioning in them, which means part of that function, the kidney was wasted. It could have saved somebody else's life, got somebody off dialysis for longer. So that concept of utility comes in as well too. So that's the big picture we need to talk about. So because of that, transplant centers are regulated for your success rates. They want to make sure that you're maximizing your function. Now, transplant centers, when the regulation, you're given risk credits. For example, we know for so many reasons, African Americans don't do as well as transplant. So if you transplant an African American, the government kind of expects that you will not have the same success rates if you transplant an Asian versus a white person.
So is that because the health indicators for
no,
Americans are lower?
No, it's because of so many reasons. Now, you can blame economics, you can blame biology, you can blame the underinsurance, but there are so many reasons that potentially that might happen. But as a population, African Americans tend to do worse after transplant than any other race. So because of that, the government gives you credit, risk credit, to transplant an African American. They expect that your failure rate is going to be slightly higher, so they actually give you a little bit of wiggle room. But imagine that if all transplant centers are graded on a 5-grade scale currently, which is an issue sometimes because it's kind of like a Yelp scoring system. And if you actually look up the national results, which are published every 6 months for everybody in the country to see, especially insurance company and patients population. They can choose which transplant centers to go to based on the success rate. So every transplant center wants good success rates because they have to look good to the patient. They have to look good to the insurance companies. Otherwise, you will be punished. If your success rates are not as good, you will lose centers of excellence. Patients will choose not to come to you, and the government will kind of sanction you.
Okay. Dr. Harrison, I'd love to hear your response to all of this.
I mean, there's so many thoughts and, just learning on each of these. And I want to say how much it's an honor to be here. Dr. Callender, Dr. Abbasi, and Dr. Paramish, who's a neighbor of ours. So it's wonderful to be in this capacity. One of the things that that resonates with me was what Dr. Callender had brought up was the disparity and how much of a need for education. We work, Joey and I work on the donation side. So we work specifically with the families that have had a loss. And that is a very intimate place to be with the family. And Joey and I both in our early lives with Louisiana Organ Procurement Agency used to be family advocates that would sit with these families at that time of a acute loss. It was very difficult. And not only for us, but for the hospital staff, but primarily for those families. And so going back to what Dr. Callender had spoken about as far as for the education, because us as family advocates supporting the family, it's not just for donation purposes. Every family should be supported during a time of loss, regardless if they have an opportunity to donate. However, when there is an opportunity for their loved one to become a hero and to save the lives of others, then that's an additional supportive role that we play. And what we've always talked about is the importance is having those conversations prior to a family being in that situation. You don't want the first conversation about what would you do if your loved one died in that setting, especially now. We had brought up COVID, which is so difficult because you have families that are all alone, that maybe have one visitor, two visitors. The visitations are very restricted and those types of things. So whoever our family advocate or that nurse or that physician that is with that family, that might be the only person that they have at that time. And so making sure that you can support them, not just if donation is an opportunity. However, we look at a number of things as far as for when we're supporting a family. Our family advocates are very trained as far as for supporting families and in working with them. Sometimes it looks very simple as far as for being specific to those basic needs on what families need. And but sometimes simple is often overlooked. And so I could go into a lot of different things. I know that we had spoken about things as far as for building that trust and the challenges that take place. But going back to it, the education in the communities and making sure that these myths, can be talked about, whether it's if it, you have a heart on your driver's license or if they're going to save you in the ER, any of those things, so that families can focus on the most important thing and that's themselves and their loved one, and the decision that they have is an opportunity to save someone else's life and their loved one to be a hero.
We had said in an earlier program, as I alluded to when we got started, and Shawn-Paul was part of that conversation earlier, late last year, about the trust and all of us being co-workers in this process. And co-work is everybody down to the guy who mops the floors in the room, up to everybody, up to the surgeon, that we're in this together. And it is quite evident for the guest we have today. But how do we maintain trust? If you have to tell a family that Uncle Joe, not Joe, because we got Joey here, Uncle Fred, Uncle Fred cannot get the transplant because Uncle Fred is schizophrenic. Now, Uncle Fred could be a great candidate for that liver, for that kidney, okay? But because Uncle Fred is schizophrenic, we're gonna give it to somebody who hasn't been diagnosed with schizophrenia. How do you keep trust together when that happens? And anyone can answer that question.
The concept of mental health disorders is by itself not a contraindication to transplant. It's the question that it's untreated is the issue. We alluded before that transplant centers are graded upon your success rate. So, and plus we're trying to kind of look at utility as well as equity. So the choice is trying to give it to somebody that has a chance of making it better. So the rules and regulations that we follow, UNOS makes the rules as far as what way to follow. And as far as mental health, they kind of say that a psychosocial evaluation should be performed. And CMS, which is the largest payer for transplant, has in their guidelines that a psychosocial evaluation should be performed. That's all they say. Now, how they choose to kind of interpret that is different. But, that's correct. But the issue is who is responsible for maintaining that person? So if the person has a psychiatric disorder, why are they not seeing somebody for it? The job for a transplant center is to make sure that you have passed all the tests to qualify for a transplant, mental health being one of them. I mean, they've got to all get their cancer screenings, right? So if somebody had an active cancer that you found, we can't transplant them either. If somebody has a bad, heart disease or something that they can't qualify for transplant, that rules them out as well too. If somebody has an untreated, significant psychological disorder, why can't they get that treated first?
I don't understand, Dr. Paramesh, why me being, psychotic has anything to do with whether or not I can carry that kidney.
Well, are you going to take your medicines the way you're supposed to, or are you going to listen to voices in your head that tell you that you should not take the organ and stuff? So our job is to help maximize the success of that organ. If you take that organ, are you responsible for it? I mean, this is a valuable gift that you have gotten. Somebody has to die for you to get this organ, and you got a scarce gift that other people are. The fact that you got a kidney means that other people are dying because they didn't get that. So I'm going to give it to you. I need to know that you're a good person. You're going to take the organ, take care of that organ. I tell patients that getting an organ is something like being pregnant. You've got something living that's put inside of you that you have to protect for a long time. And just like you have a mother that will protect that child by watching what they eat, watching what medicines they take, not smoking and drinking while they're taking care of that baby, you have a kidney inside you, which is like a baby that's living inside of you, and you have to protect it. It's not like any other surgery that I take out your gallbladder, you wait a couple of weeks and you're done. This is going to change your life, and you have to be monitored for the rest of your life, and you have to protect that organ. And if you can't protect it by yourself, then that may be an issue.
Dr. Callender, your response, because there is a lot of, you're muted, Dr. Callender, there's a lot of diagnosed mental health issues in the Black community. And as Dr. Abbasi has said, it's exacerbated by COVID. I mean, even the person who had the mildest depression right now may be over the top. They've been isolated. Several people in their family have died. I mean, my sister was living in a nursing home, and I could not touch or hold her for the year before she died. She just died in last year. So she was in a nursing home. We couldn't go visit her. So she didn't have a hug. She didn't have anything for a year. And that affected me too.
Right.
That I can't go visit her because I, was always in her room. So there's a lot of depression, a lot of mental health in the Black community. So as Dr. Paramesh so clearly made clear to me that this is a precious thing that if you can't take care of it, you can't hold it. So how does that affect the African-American community?
Well, I think Dr. Abbasi kind of put it into perspective that the real issue is not that they have a diagnosis, but they either have a treated or untreated diagnosis. And as all have mentioned, especially in our community, the stigma for mental illness is enormous. And so many of our people of color won't go to a psychiatrist. And so it therefore becomes imperative that somebody with mental illness is treated, or else they would not get a kidney. And I would argue, or liver, and I would argue that that is the right thing to do. In other words, not saying that the mental illness prevents you from getting the transplant, but saying untreated mental illness may prevent you from getting it transplant. Just like with some cancers, you have to wait for some cancers to wait 2 to 4 years before the cancers are eliminated. And so the same common sense and medical appropriateness is required for mental illness as well. So not one size does not fit all. It is important if you have a diagnosis of schizophrenia or whatever it is that you be treated. And if you're treated and controlled, then it's just like, for example, we now do transplants for HIV positive patients, but they have to be controlled, and it's no different for mental illness.
Joey,
but your point about it affecting us
add
more than any other ethnic group is accurate.
Yes, okay.
So
Dr.
I would like to add just one more thing. I do understand that everybody has to be in a competent mind to be able to take care. It's a precious gift. We don't have enough. So they should be in a mindset that they know that what it means. The problem that I see is, yes, I'm a big advocate that mental illnesses should be treated, and we know early interventions, we have better outcomes. Even for schizophrenia, early intervention, being on treatment, you can have very good, healthy outcomes with that. That said and done, what about those who cannot be deemed mentally competent even after treatment? How are you going to deal with that dilemma? It's like treatment supported. So yes, I think if mental health becomes part of this conversation from the beginning, having a psychosocial evaluation, but we also know that even if you have not been diagnosed with depression, anxiety before transplant happens, you can go on to develop severe depression or anxiety or psychosis. The immunosuppressant meds in itself can be increase the risk. So one thing is, yes, ideal world, everybody should be treated. But what about if you have an illness that cannot be treated? Like I was reading about the case of the child with autism, with Down syndrome, how the mother had to fight to get him a heart transplant. So there are gray areas. So I think you said something, we are co-workers. I think we need to be stakeholders. We have to, all of us have a stake in this process. And it starts with education, awareness, acceptance, and improving access. So the flow has, and I think mental health has to be part of all stages of it.
Okay, thank you. Joey, how does this affect your work? I mean, you have to, you're dealing with the getting of the organs, and you have to make sure that organ is right to go to that person. But how does this conversation affect your work?
So where the connection is made for us oftentimes is actually one of my favorite parts of my job is when the transplant recipient and those donor families meet. And of course, that is one of our jobs along with the transplant center jobs. I know, both Paramesh and Callender have probably experienced quite a bit of these, right? Of these meetings, and I know Shawn-Paul has as well. And I would imagine, so for us, I know Dr. Abbasi had talked about the mental health, like depression, especially. That is one of the most joyous occasions that brings some light to what has been a challenging situation on both sides. It's you've had, on one hand, you've got a recipient who may be fighting all kind of challenges, depression and things like that, and then knowing that they may never get that second chance at life, and then getting it, and then having grief sometimes because they get to live on and this hero doesn't. And that connection, of course, and then that can lead to further depression. Mm-hmm. And so what we try to do is, as often as we can, is provide correspondence. We don't put limitations. We don't say you have to wait a year, or anything like that. When that recipient and that donor family are ready to meet, it's not our job in that situation to block anything, because of this very reason, because they need it from the donor family side to help at least benefit their grieving, accelerate their path to healthy grieving, and on the recipient side, again, to help with some of those depression issues and grief issues that they're fighting as well.
Shawn-Paul, would you like to add to that?
No, I mean, I completely agree with Joey, and all the, him 20 years and my 19, seeing so many of these donor families, that loss was almost a death to them. I know specifically, there's a mother that, told us that in her son's giving gave her life. And, that's a tremendous thing because it does, it doesn't avoid them from having a very difficult journey of grief, of depression and sadness. However, it can lead them into a direction to have a healthier life for them and their family. Because oftentimes these donor families and these recipient families become families. It's not just a donor family and recipient. It's a true family that's combined from that specific gift, like Dr. Paramesh was talking about. So it's a tremendous thing to see as far as for how that unites these families and that gift through death and donation.
Dr. Paramesh, Joey mentioned that you have been in these kind of meetings often in your career. Tell me about them.
So I work as the medical director for the Louisiana Organ Procurement Agency, so I know Shawn and Joey pretty well. But remind me again, which meeting exactly we're talking about? Meetings between who and whom?
Joey.
I was saying when the donor families and the recipients meet,
That's right, yeah. So it is a beautiful thing. I mean, many times when we do the organ donation, the recipient doesn't necessarily know who the organ came from, right? But there is a way, and different OPOs do this different. After a couple of months, you can write a letter to the recipient can write a letter to the donor family, letting them know that, hey, I got your organ from your loved one, and I'm so grateful. I'd like to meet you if you want to. Now, this letter is shared with the with the donor family, and the donor family has the right to choose if they want to meet the recipient or not, because you got to see it from their perspective, right? I mean, they lost a loved one from this, and in their mind, they may want to meet that person to see, to hear the heart of their loved one or to feel the liver of their loved one, or it might be a very tragic scenario that they want a chapter closed, that they don't want to meet them because it's just going to bring back memories.
Yeah.
So I've seen it happen both ways, where the donor family did not want to necessarily meet the recipient, but more often and much more happily, many donor families do want to meet the recipients, and it's such a joyous occasion when they do meet. They become like family again, and part of my loved one is in you. They spend Christmas and Thanksgiving, all that together.
That's beautiful.
So that's, of course, it's a beautiful thing that happens.
Yeah. So part of what we're going to be doing with this program is like what we've been doing moving forward. I think everyone here has expressed that we need more donors. We need more of the community to be part of the donor community. And every show I get to say, I am a donor, I'm an African-American, I'm an elder by some people's standards, and I still want my body to do something for somebody, because I'm just going to cremate it away. So you might as well take what you have, what I have, because I do believe that it's our job to give what we have, wherever you can get that. So we're going to be doing that moving forward. And I really hope that each and every one of you will be a part of that. Dr. Callender, welcome to the fold. Joey, welcome to the fold. And I'm hoping that we can do that moving forward. But I want to begin with Joey, and then I'm going, Shawn-Paul was just finishing, so I'll begin with you. If you had the opportunity to talk to someone who is not a donor, and you had a few moments, just a few moments to tell them why they should do it, what would you say? And I'm going to ask everyone the same question.
Oftentimes it's a reflection of that person and who they are. I know it's not directly answering your question, but I know that whenever we're speaking with the family and they don't know what that decision was, maybe they weren't registered, which doesn't mean that they didn't want to be a donor. We often want to bring that person, that their loved one that has died, into the room, into that conversation, to share more about the person that they are. And oftentimes it leads them into stories and the kind of person that they were and are that would want to give to other people. And that's truly what this is, wanting to help others. So it's more or less reflecting about who that person is and what donation provides, not only to these recipients and saving lives, but also to them, like I referred to in that healing process.
Okay. Dr. Paramesh.
So I'll use one of my favorite phrases I've seen many years ago, and it kind of goes back to what Dr. Callender said, please leave your organs on earth for other people, because God knows you don't need them in heaven.
Mhm. Very good. Okay, Joey?
For me, it's simply that you're going to leave a legacy. You're going to have a ripple effect that you can't even imagine, not only for potential recipients and maybe their children and their grandchildren that they wouldn't have had, and all the friends and family that you've touched because of that, but for your own family and to propel them during their grief journey, because they're going to have a grief journey when you're gone. And that the benefits that I've been able to witness from those families who said yes is tremendous.
Okay, thank you. Dr. Abbasi?
I think as a coming from Islamic perspective, I would like to say that saving a life is saving humanity. So it's part of my profound purpose on earth, to serve, and what other best way to live longer is to live vicariously through someone else.
Dr. Abbasi, before we go, I get to Dr. Callender for that answer. You invited the leadership of the Muslim Planning Life organization that has put us all together to come to your conference. Tell me why you would extend that invitation.
Again, I think because I want to create more awareness around organ transplantation. And I think it's best to, like, we have talked about trust deficit, and I feel like the trust deficit also comes from the fear, not knowing. And Muslim Mental Health Conference has been an established conference for 14 years. People trust it, people feel safe, people can open up there, and it's the best place to have these profound conversations.
So you invited Samuel and Kareem to come because what does their organization bring to you?
So that we can have this conversation, that people get to hear the good work that's being done and the need to do more, need to dispel the fear around organ transplantation. So have these conversations there.
Okay, very good.
Create more awareness to improve the numbers of donors in the community.
Okay, thank you, Dr. Abbasi. You wanted to say something else?
No, I just feel that we absolutely, again, one thing, common thread that's coming out is that we need to create more awareness around it. We need to have more conversations around it.
Because I'm assuming that the Muslim community has the same deficit of donors that the African-American community would have, correct?
Yes, I did, just a personal thing. My sister-in-law, she passed away very young. She was only 40 of a brain aneurysm, and we were in that situation. And we were few of the first families that opted to donate her organs. And it went to a very young girl, her heart. And we did connect with the family, and it was one of the most cherished memories for her kids.
Very nice. Thank you for sharing that with us.
Yeah, thank you, Dr. Abbasi.
Yes, thank you. Last but never least, Dr. Clive Callender, if you had an opportunity, and which you do all the time, to tell people of any race why they should become a donor, what would you say?
Well, what I have said actually is that it isn't giving that you receive. It's in pardoning that you're pardoned. It's in dying that you're born to eternal life. So that it is the right thing to do. And I think today I've heard one of the most balanced conversations I've ever heard, to put things into perspective. I'd add also to this that some people just aren't healthy enough to give organs. So they can also give tissues that can enhance lives, can make the blind see, the deaf hear, the lame walk again, so that it is in this gift of life that we can help others. That's what I would say and have said.
Okay, very good. I want to thank you all, first and foremost, for the service you perform. the dedication of your lives to save other lives. Something you don't have to do, but you choose to do it year after year after year. And it is a proud privilege of mine to sit in a room with you all to do this healing work. I want to thank those in the audience who have joined us each and every one of our sessions. And I'm looking forward to the next one and seeing you all again pretty soon. For Profound Conversations, I'm Joya Jefferson Nuri. Stay blessed.
Thank you. And stay sane.
And stay sane.
Thank you.
Thank you. Yes.